In chapter 10, we'll start to talk about kind of how we measure it all and what are some of those big performance metrics that we look at, as well as some of the supporting organizations that play a role in that around things like, as you can see here, licensure, certification, accreditation. And these kind of three words, licensure, certification, and accreditation, are often interchanged, and it's not always correct. In fact, it's usually not. So we'll kind of talk about that, define some of those a little better, hopefully, and look at some of those measures that we do use to look at the overall effectiveness of our organization. Okay, so like I said, here you can see some of the key topics we'll talk about today in this chapter 10. So to start off, let's define a few things. Licensure, that gives a facility the legal approval to operate. Okay, this is done at the state level. Okay, and there is at the state level, that's who oversees licensure of healthcare facilities. Now, these are things like, in a lot of cases, ensuring things at the basic of level, right? Do we have exit signs? Do we have a fire suppression system? Are the stairwells lighted with emergency lighting in the event of a power failure? All of these things that any building that would receive commercial traffic would be expected to have. Okay. Next level up from that is certification, and that gives the healthcare entity the authority to participate in the federal Medicare and Medicaid programs. Of course, Medicaid is administered at the state level, but you have to be certified federally to be involved in this. They also provide the CMS, or Centers for Medicare and Medicaid Services, those minimum standards for what we call a COPS, or conditions of participation. Okay, accreditation, that is voluntary. You can be an operating healthcare entity without having a single accreditation. That said, you're probably not going to get a lot of business either. All major healthcare entities carry multiple accreditation. And as you can see, this is a voluntary process, but there are some pretty big incentives for becoming accredited. All right. And a lot of it has to do with reimbursement. Okay. Number one, let's talk about Joint Commission, or you'll often hear them referred to as the acronym JCAHO. Okay. They're independent. They're not for profit. It is the most common agency used to accredit hospitals in the United States. They'll complete a site survey every 3 years, meaning someone is going to show up, a lot of people are going to show up every 3 years and inspect. It is 2 years for reference laboratories, just because the risk is a little bit higher there. Okay. They do release a standards manual every single year that lists all of the criterion and conditions. Okay, they can issue one of 6 different rulings after their site survey visit. Okay, we're giving you preliminary accreditation. We're giving you full accreditation. Both of those kind of stand on their own, right? Preliminary means, yep, we see this oftentimes if a hospital's under construction, right? It looks like you're going to finish. It looks like everything is going to be good. We're going to say you have preliminarily passed the accreditation requirement. Accreditation, this is the absolute best you can hope for. Accreditation means that the site surveyors showed up, they had no major concerns, they issue full accreditation, and they say, we'll see you in 3 years. Okay. Accreditation with follow-up survey, that means you've got some things that concern them. They're going to come back in less than 3 years and check you out again and be sure you've done what they've told you to do. Contingent accreditation is just what it sounds like. If you do this, we will issue full accreditation. Okay. Preliminarily denial of accreditation is just that. We have been alerted of some issues. We're giving you a preliminary decision that we're denying your accreditation, and you can still continue to operate, but we're showing up, and when we do, just count on getting your accreditation revoked. Okay. And then last is a full denial of accreditation for the most egregious concerns issued by Joint Commission, and it is revoked immediately. Okay, some of the standards that Joint Commission puts out there is what they call the record of care. The text abbreviates this as RC. Sometimes you'll see it as ROC. Okay, this is what content Joint Commission has declared that is necessary for a complete health record. Not picky on the format, but it has to have all of this content. Okay. It also puts a bunch of standards in place around information management. And it's important to note that this applies to both computerized and non-computerized systems. So if back in the old days when organizations didn't have a lot of electronic records, Joint Commission would spend a lot of time in the medical records department looking at how they stored and cataloged all of their records. NCQA is the National Committee for Quality Assurance. That is the top dog, if you will, when it comes to accrediting a health plan. Okay, so something like your Aetna, your Humana, your Blue Cross, and your Blue Shield. They look across the organization to see, do we have quality management plans in place with opportunities for improvement? Okay, are we getting better? Okay, how are we utilizing our resources? Are we ensuring that everybody is getting credentialed and staying credentialed? Okay, are we taking care of our members, our plan members, aka the patients, right? Are we working with Medicaid properly? And then a term you'll see an acronym you'll see pretty often is HEDIS, Health Effectiveness Data and Information Set. And we'll talk a little bit more about that here shortly. Okay. We also look at the quality of care. And one thing that the text has called out a few different times is the IOM study, okay, in 2001. And then there was another one that came on the heels of that. Okay. And it basically laid out the 6 aims for quality healthcare. And even though this is, really old now, I would argue that all of these are still very applicable, right? It has to be safe, effective, patient-centered, timely, efficient, and equitable. Pretty straightforward. Okay. When we think about quality of care, we look at where the data comes from. And this is a really good way to kind of bucket that data, if you will. So administrative data can be things like your claims databases. Okay. Disease registries, this is where we keep a listing of everybody with condition X, right? So for example, there's one for diabetes, there's one for heart disease, there's one for liver disease, all of those things, okay? And it gives us kind of a one-stop shop if we need more information on people with a given health condition, okay? The health record, of course, as we've talked before, that is the detailed patient information of a specific patient. And then our qualitative data. And some of this I'd argue is quantitative as well, because it's data from patient surveys and interviews. So you may have never filled out a patient survey as a patient of a hospital, but I guarantee you've all seen some of the various types of surveys that are out there. And in many times you're asked to score yourself with or provide a score of, overall, I was, satisfied with this service. Okay. And you would say highly agree, somewhat agree, neutral, somewhat disagree, and strongly disagree. Okay. And there's a number associated with each one of those scores. So then we can take those scores and we can come up with an average and report that data. Okay. Okay. So when we talk about those data sets from the slide, a couple slides back, those are our healthcare performance measures. Okay. Over 90% of health plans in the US are collecting and reporting this data. Okay. Along with that are what we call CQMs, clinical quality measures. And again, CMS updates these every single year. And this is developed by, a mix of private organizations, your healthcare societies, various collaborative groups, and even government agencies. And this is one of the many things that Joint Commission looks at during their site visits. Okay. So we got all the data. What do we do with it? Okay. Well, one way we can do it that is frankly the easiest is what we call benchmarking. Okay. We look at one of our performance measures against another, okay, against a quality standard. Okay. So for example, we could look at something like our patients that are admitted to the hospital with influenza. How long do they stay in the hospital? We can then benchmark that or compare that to other hospitals that have reported in this data. We can also benchmark against ourselves. We can look at how long patients stayed a year ago prior to what they do today. Patient satisfaction data set, same concept. We can compare ourselves to how ourselves were doing a year ago, 5 years ago, 10 years ago. We can also compare to national averages. Very useful. Okay. There's a lot of organizations that have provided basically practice data sets, and the Dartmouth Institute is one of them, where they provide several of those data sets that you can use just as kind of reference points to help get you into that space. Okay. Again, a couple more examples here, talking about the NCQA report cards. Those can be found here. Those are kind of fun to go look at and just get an idea of what's going on out in that space and kind of see what's getting reported on and overall how we're doing. Okay. So at the federal level, we have the Patient Safety Act. Okay, so there are PSOs, patient safety organizations, that collect and look at this information, and they start to analyze and say, how are we doing? Okay, and they talk about a patient safety work product. Okay, so we look at things like incidents, near misses, or sometimes a close call, if you will, and unsafe conditions. And then we analyze that and we say, how do we do better? Okay. How do we stack up to other organizations? Okay. What's the difference? Why are they doing better than us? Why are we doing better than them? Okay. Part of this, when you look big picture, is you've got to have a strategy in place. Okay. And there's some frameworks out there, the Affordable Care Act, or ACA, helped to put some of these in place. And really, it kind of looked at three things as a whole. Okay. And it puts it into some pretty big buckets, but I do like this model. Better care. How do we, when I do need care, how do I do better at it? Okay. How do I ensure that less people die in the hospital? How do I ensure that people stay in the hospital a shorter amount of time? How do I ensure that when people do show up at the hospital, that I treat them right the first time and they don't have to come back? Next, more of the proactive side of that. How do I keep people healthy so they never have to come to the hospital? Okay, so looking at healthy communities. And then last, the affordable care. If I need care, how do I ensure it's care that I can afford? What am I doing to keep costs down and manage all of that? Okay, then you can see on the right some of the things that we can do to help push this along, kind of the carrot and stick, if you will. As you can see, technology plays a role in that. Training our workforce is big, but again, it's measurement and feedback. Okay, look at what we're doing and look at where we've been and look at how we can improve upon it. Okay. And then, of course, we would be remiss if we didn't talk about how is payment linked to this, right? So we talk about things specific to reimbursement. So HVBP, hospital value-based purchasing. Okay, so I'm looking at where I make my spend relative to my population, and can I do more with less and still get healthier outcomes? And the answer is I can, sometimes if done properly. We also look at, I mentioned earlier, readmission reduction. How do I treat people, get them out the door of the hospital, and ensure they don't come back? And they don't come back because they've been treated right the first time. The big one that Medicare has been really watching in the last decade and a half, that they'll continue to watch, other health plans besides Medicare are watching this very closely, is something called hospital acquired conditions. Okay, so how do we ensure that when a sick person comes into the hospital, they don't get sicker, right? So a patient comes in with a broken arm, they need to have surgery, and suddenly they end up with the flu on top of it, and then also maybe a surgical site infection. Okay, so Medicare has been more aggressive in trying to stop this, and it has had some success, but still have a long ways to go there. Okay, and then also we talk about the Medicare Access and CHIP reauthorization, which is the acronym MACRA. We've talked about this in a couple other chapters as well. And again, this just tries to put into place what we call a merit-based incentive payment system, which essentially says, if you as a provider do a better job and have better outcomes, I'm going to pay you more. So I'm incentivizing you to keep people out of your exam room, if you will. Okay. So we kind of talked high level about a lot of stuff in this unit: licensure, certification, accreditation, joint commission, the quality mechanisms behind it. Talked a little bit about the different types of data sources that we can look at respective to quality, some of those, measurement organizations, the data sets that are out there to support us as well. Some of the federal initiatives around quality improvement. I'll pause there to say there's also a lot going on at the state levels, but it's kind of more nebulous. It's a little harder to keep up with. And, every state is different, so I don't really get into the state level. If you're interested, reach out to me. I can point you to some of the places you can go in your given state to find some more information there. Okay. And then of course the CMS initiatives around, the value-based purchasing, the macro MIPS programs and the impacts that they have. And we're still starting to see these evolve. So it'd be interesting to watch these. So that concludes chapter 10. And please let me know if you have any questions.